Welcome to the deep dive. Today we're plunging into a topic that carries, well, just an immense global burden and represents such a profound personal tragedy for millions: diabetic foot disease.
It's staggering when you look at the numbers.
Absolutely. Over 380 million people worldwide affected right now, and the predictions soaring to nearly 600 million by 2035.
And that statistic about amputations, it really hits home.
It does. Somewhere in the world, an amputation happens because of diabetes every 20 seconds.
Yeah.
It's sobering, and it really underscores why we're doing this deep dive today.
Definitely.
Our mission here is to give you a crucial exploration into the very latest clinical practice guidelines for managing diabetic foot.
And these aren't just any guidelines. They come from a really distinguished multidisciplinary committee. We're talking the Society for Vascular Surgery, the American Podiatric Medical Association, and the Society for Vascular Medicine all collaborating.
Right. Offering an evidence-based, structured approach to what is, let's face it, an incredibly complex condition, our source. It's the guideline document itself, the Management of Diabetic Foot, a clinical practice guideline.
Yeah.
So it's direct, it's authoritative.
You know, what's really fascinating here, the real game changer, is how these guidelines finally bridge those historical gaps between specialties. It's not just about having a unified strategy on paper.
Right.
It's about actually getting podiatrists, vascular surgeons, endocrinologists, getting everyone to integrate their efforts right from the start. That multidisciplinary synergy, that's the key insight, I think.
Yeah.
Moving us from fragmented care to something truly holistic.
Absolutely. And to help navigate this complex landscape, we've structured our deep dive around 5 critical areas, basically mirroring the guideline itself.
Okay.
So first, we'll delve into the prevention of diabetic foot ulceration.
Makes sense. Start at the beginning.
Exactly. Second, we'll look at optimal offloading strategies for existing diabetic foot ulcers. Third, tackling the precise diagnosis of diabetic foot osteomyelitis.
A really tricky area, that one.
Definitely. Fourth, we'll explore comprehensive wound care for diabetic foot ulcers. And finally, fifth, the critical role of peripheral arterial disease in diabetic foot management and, importantly, revascularization.
Got it. A clear roadmap.
Okay, let's unpack this. Diving into these guidelines, it's really about equipping you, the listener, with the most current, actionable knowledge. Stuff you can use to make a tangible difference in patient outcomes. Moving from just reacting to problems to being proactive, focusing on prevention. So if we're tackling diabetic foot disease, prevention has to be front and center, right? Where do these guidelines recommend we start? What's the baseline for routine screening and ongoing care?
Well, the cornerstone, the core principle is annual foot inspections for all patients with diabetes.
Annual.
Okay, and these need to be done by physicians or advanced practice providers who are actually trained in foot care. It's not just a quick glance. And beyond just looking, a thorough history is key.
Yeah.
You absolutely need to ask about any prior foot ulceration or amputation. Those are huge red flags, strong predictors.
Okay.
Poor visual acuity also matters more than you might think, because it can seriously hinder their ability to do self-checks and self-care.
Right. Makes sense. And the physical exam itself, the guidelines get pretty specific there, don't they? They strongly recommend testing for peripheral neuropathy using the Semes-Weinstein 10-gram monofilament test.
That's right. It's considered highly accurate for picking out those high-risk patients.
And it sounds simple, but could you just describe it quickly for anyone not familiar?
Sure. Imagine a thin, flexible filament. You press it against specific points on the bottom of the foot until it just starts to bow.
Okay.
The patient, with their eyes closed usually, just says yes or no. Can they feel the pressure? It seems almost deceptively simple, but it gives you crucial information about whether they still have protective sensation. Loss of that is a major risk factor.
Got it. Simple but powerful.
Exactly. And beyond the monofilament, you absolutely must palpate the pedal pulses, get a sense of their vascular status, even at this early prevention stage. Clinicians also need to look carefully for any foot deformities, things like hammer toes, claw toes, bunions, maybe even early Charcot changes.
Because those create pressure points.
Precisely. Those structural changes often lead to abnormal pressure points, callus formation, and those calluses can break down into ulcers, so you're looking for trouble spots.
Okay.
And finally, a really meticulous inspection of the toes themselves, and crucially, between the toes. Look for fissures, hidden calluses, any nail problems, things patients might miss themselves.
That detail about checking between the toes is so important, easy to overlook.
Very easy.
But even with the best clinical checks, it feels like patient engagement is key. Which brings us to patient and family education. The guidelines emphasize this, right? Educating patients, their families too, about preventative foot care.
They do. It covers basic foot care practices, how to manage calluses safely, nail care, and something really critical, proper shoe fitting.
How strong is the evidence for education making a difference on its own?
Well, that's an interesting point. Logically, it makes perfect sense, right? Education should help. But when you look at specific studies focusing just on education interventions, the evidence is often graded as low level.
Oh, really?
Yeah, they show only modest improvements in outcomes directly linked just to the education piece. But here's the caveat, and it's a big one. Compliance is absolutely key.
Oh, okay.
The best advice in the world doesn't help if the patient doesn't follow it consistently. So education is vital for enabling compliance, even if measuring its direct impact is tricky.
Got it. Education empowers adherence, which is effective. Now let's shift to therapeutic footwear. This seems to have some nuanced recommendations.
It does. It's not one size fits all.
So for average risk diabetic patients, what's the guidance there?
For that group, the guidelines actually suggest against the routine use of specialized therapeutic footwear. That's a grade 2C recommendation.
Against. Why is that?
The reasoning comes from some large trials. They looked at patients who had healed ulcers, so they were at some risk, but maybe not the highest. And these studies didn't find a significant difference in re-ulceration rates between those wearing specialized shoes and those wearing appropriate regular footwear.
Okay, so for the average risk person, maybe it's overkill or just not proven necessary routinely.
Sort of, yes. But now, contrast that sharply with high-risk diabetic patients.
Okay, who are we talking about here? High risk means?
High risk explicitly includes those with significant neuropathy, like loss of protective sensation found with a monofilament test or existing foot deformities, or importantly, anyone with a previous amputation.
Right. And for them?
For them, the recommendation flips dramatically. There's a strong recommendation, grade 1B for custom therapeutic footwear.
Grade 1B. So good evidence.
Yes. Very good evidence. This is where it becomes compelling. There was a large randomized controlled trial, almost 300 high-risk patients, and it showed nearly a 50% reduction in new ulcers over 5 years when they used custom orthoses along with regular foot care.
Wow, 50% reduction. That's huge.
It is. It highlights just how much improper footwear contributes to ulcerations in this vulnerable group, so getting the shoe right is vital.
And what makes footwear therapeutic in this context? What features should we look for?
Good question. We're generally looking for things like a broad, square toe box, no pointed toes squishing things. Laces are usually preferred over slip-ons for better fit adjustment. A padded tongue helps. Quality materials that breathe but also protect. And critically, enough depth and width to accommodate a custom or cushioned insole without crowding the foot. It's all about reducing those peak pressure points and distributing weight more evenly.
Makes sense. Design follows function reducing pressure. Okay, moving on slightly. The guidelines also touch on glycemic control, right? Suggesting adequate control, specifically a hemoglobin A1C less than 7%, while trying to minimize hypoglycemia.
Yes, that's a grade 2B recommendation. The aim is explicitly to reduce the incidence of diabetic foot ulcers and infections, and ultimately, the risk of amputation.
And the evidence backs this up.
Oh, absolutely.
Yeah.
The evidence here is quite robust. You've got landmark studies like the UK Prospective Diabetes Study, and also systematic reviews and meta-analyses. One big meta-analysis looked at 9 trials, over 19,000 patients.
Wow.
And it showed that intensive glycemic control aiming for that hemoglobin A1C between 6 and 7.5% significantly decreased the risk of amputation. The relative risk was down to 0.65.
So a significant reduction.
Definitely. Although it's worth noting, the benefit might be less pronounced in patients who are already very high risk for other reasons. But overall, good glycemic control is a clear preventative factor.
Okay. And then there's a very clear don't in the guidelines regarding prophylactic revascularization.
Yes, this is important. The guidelines strongly recommend against doing prophylactic arterial revascularization just to prevent a first diabetic foot ulcer. That's a grade 1C recommendation.
So don't fix arteries just in case an ulcer might form later.
Exactly. It might seem logical, like improve the blood flow, prevent problems.
Yep.
But there is simply no trials that show this works for primary prevention of ulcers.
Okay.
And you have to weigh it against the risks. Diabetic arterial disease is often complex, diffuse. Invasive procedures carry risks, infection, vessel injury. Doing that without a clear current problem like severe claudication, rest pain, or actual tissue loss. The benefit just isn't apparent. Pre-vascularization decisions should be based on standard indications, not solely to prevent a first ulcer in someone who just has neuropathy.
That's a really crucial clarification. Avoids unnecessary intervention.
Absolutely.
Okay, so just to quickly recap this prevention section, the core tenets seem to be regular, thorough foot inspections, including that monofilament neuropathy testing, targeted patient education focused on enabling adherence, then therapeutic footwear but specifically for high-risk patients, not routinely for everyone, maintaining adequate glycemic control, aiming for that A1C under 7%, and finally, being judicious with revascularization, use it for established disease, not prophylactically to prevent a first ulcer.
That sums it up nicely. A multi-pronged approach is essential.
Right. Okay, let's try a quick clinical scenario based on this. Imagine you have a 58-year-old patient, type 2 diabetes, pretty good hemoglobin A1C at 6.5%. He's in for his annual physical. No current foot pain, but he does mention some tingling in his feet sometimes. Never had an ulcer or amputation. What's the most appropriate next step in his foot care management based purely on these guidelines? Is it A, immediately prescribe custom therapeutic footwear, B, recommend an ankle brachial index measurement, C, perform a Semes-Weinstein 10-gram monofilament test, or D, schedule prophylactic arterial revascularization?
Okay. Thinking through the recommendations.
Take a moment, consider the guidelines.
Well, the annual inspection is key, and part of that is neuropathy testing. The tingling is a symptom suggesting possible neuropathy. So
the answer is C, perform a Semes-Weinstein 10-gram monofilament test.
exactly. That's the immediate next step, recommended by the guidelines for all diabetic patients annually, and especially relevant given his symptoms.
Right. Custom footwear A is only for confirmed high-risk patients, which we don't know yet. An ankle brachial index, B, is suggested when patients hit 50, so it's relevant maybe, but the monofilament test is more specific to the immediate preventative check and his symptoms, and prophylactic revascularization, D, is explicitly recommended against.
Perfect rationale. The monofilament test is the direct application of the screening guideline here.
Great. Now let's pivot to when prevention hasn't worked or maybe wasn't implemented, and we have an ulcer. We've all seen those stubborn plantar ulcers, right? The ones on the bottom of the foot that just seem to linger. It often boils down to one fundamental issue: pressure.
You've absolutely nailed it. Pressure is the enemy of healing for plantar ulcers.
So what do these guidelines tell us about effectively getting that pressure off the foot? What are the optimal offloading strategies?
This is such a critical section because, as you said, most plantar ulcers are caused by repetitive or high plantar pressures. That pressure must be relieved for healing to happen.
It's not optional, it's foundational.
Exactly. It's a foundational requirement. It has to happen alongside any other wound therapy you're doing. And the same principle applies to non-plantar wounds, too. You have to relieve the pressure wherever the wound is. But for plantar ulcers, it's particularly emphasized.
Okay. So what are the primary recommended offloading methods for these plantar ulcers? The guidelines are pretty clear, aren't they?
They are very clear. They strongly recommend offloading with either a total contact cast, the TCC, or an irremovable fixed ankle walking boot. That's a grade 1B recommendation.
Grade 1B again. Strong evidence. Tell us about the total contact cast. Why is it considered so effective?
The TCC has been the gold standard for a long time. Its effectiveness comes from two main things. First, it perfectly conforms to the foot and lower leg, redistributing pressure incredibly well across the entire plantar surface, taking the load off the ulcer site.
Okay, so excellent pressure redistribution.
Right. And second, and this is arguably just as important, it's irremovable by the patient.
Ah, the compliance factor again.
Exactly. It forces adherence. The patient has to wear it, has to offload, and the research consistently backs this up. Classic studies, like Mueller et al., back in '89, showed something like 90% healing with TCC versus only 32% with traditional dressings.
Wow, huge difference.
Massive. And more recently, studies comparing irremovable cast walkers, sometimes called instant TCCs, because they achieve similar irremovability, also show significantly higher healing rates compared to the same boot when it's removable. Armstrong et al. in 2005 found 82.6% healing with the irremovable version, versus only 51.9% when patients could take it off.
So making it non-removable basically forces the effectiveness.
Precisely. There was another trial, Katz et al., that found no significant difference between a traditional TCC and an irremovable cast walker, suggesting both are highly effective when non-removability is ensured. The evidence is just overwhelming. Irremovable devices dramatically improve healing rates for plantar ulcers. Compliance is key.
Okay, so irremovable is king for plantar ulcers. But what if that's just not practical? Maybe the wound needs very frequent dressing changes, or there are other contraindications.
That's a valid point. For situations where a diabetic foot ulcer genuinely requires frequent dressing changes that make a TTC or irremovable boot impractical, the guidelines do suggest a removable cast walker as an alternative.
Okay, an alternative, but maybe not first choice.
Exactly. It's a grade 2C recommendation, so weaker evidence, and it comes with a huge caution. Patient adherence plummets when they can take it off.
Right. And what should we definitely avoid for offloading plantar ulcers?
The guidelines strongly suggest against using things like postoperative shoes or just standard footwear for offloading plantar diabetic foot ulcers. Another grade 2C recommendation there.
Why? Because they just don't offload enough.
Partly that, but again, it's also about adherence and efficacy. Patients are much less likely to consistently use them correctly, and they simply don't provide the same level of pressure relief as a cast walker or TCC. They are far less effective for healing plantar ulcers.
Okay, very clear. Avoid the post-op shoe for plantar ulcers if you want healing. What about wounds that aren't on the plantar surface, non-plantar wounds?
For those, the approach is a bit simpler, maybe more intuitive. The guidelines recommend basically any modality that effectively relieves pressure at the specific ulcer site. That's a grade 1C recommendation.
So things like,
Things like a surgical sandal, maybe a heel relief shoe if the ulcer's on the heel.
yeah,
Whatever achieves the goal of taking the pressure off that specific spot, the principle is consistent. Remove the offending pressure.
got it. And once the ulcer is healed, are we done with offloading?
Not necessarily, especially for those high-risk patients we talked about earlier. Preventing recurrence is a huge ongoing priority.
Right.
So for high-risk patients who have healed diabetic foot ulcers, and again, this includes anyone with a prior ulcer, a partial foot amputation, or a history of Charcot foot, the guidelines recommend wearing specific therapeutic footwear with pressure-relieving insoles indefinitely. Grade 1C recommendation.
So the special shoes come back in, but for long-term prevention in this group.
Exactly. Adherence to wearing this prescriptive footwear is absolutely paramount for preventing reulceration. These patients often have underlying structural issues, like deformities from neuropathy or prior surgery, that lead to persistent high-pressure areas.
Makes sense.
And systematic reviews, including one commissioned by the Society for Vascular Surgery and a Cochrane review, consistently find that therapeutic shoes and insoles do reduce the relapse rate compared with just wearing regular shoes in this high-risk population.
Okay, so let's do a micro recap for offloading. It's all about strategically reducing pressure. For plantar ulcers, irremovable devices like TCCs or fixed ankle boots are the gold standard grade 1B because they work and enforce compliance. Removable walkers are a weaker alternative, grade 2C. Definitely avoid post-op shoes for plantar ulcers, grade 2C. For non-plantar wounds, any device that relieves local pressure works, grade 1C. And crucially, after healing, high-risk patients need ongoing therapeutic footwear with insoles to prevent recurrence, grade 1C. The big theme is ensuring the patient actually uses the device as prescribed.
You got it. Compliance underpins the success of any offloading strategy.
Okay, let's try another scenario. A 65-year-old patient has a non-healing neuropathic plantar ulcer on his right forefoot. He's been getting daily dressing changes for 6 weeks, very diligent, but the wound shows minimal improvement. He's currently wearing a standard post-operative shoe for offloading. What's the most appropriate immediate action for offloading according to these guidelines? Is it A, continue with the post-operative shoe, but maybe change the dressing type? B, prescribe a removable cast walker to allow better access for those dressings? C, implement a total contact cast or an irremovable fixed ankle walking boot? Or D, refer for surgical offloading right away?
Okay, plantar ulcer, 6 weeks, minimal improvement, currently in a post-op shoe.
Take a moment. What's the guidelines' top recommendation?
The guidelines are really strong on this. For plantar ulcers, the primary recommendation is irremovable offloading. The post-op shoe is explicitly suggested against. So the answer has to be C, implement a total contact cast or an irremovable fixed ankle walking boot.
Exactly. That's a grade 1B recommendation for plantar ulcers. Continuing the ineffective post-op shoe A isn't logical. A removable walker B is an alternative but less effective than irremovable, which should be tried first given the lack of progress. Surgical offloading D might be considered later, but the immediate guideline-based step is optimal non-surgical offloading with an irremovable device.
Correct. You escalate to the gold standard first.
Perfect. Now let's move into what you called a particularly challenging area. The diagnosis of diabetic foot osteomyelitis, or DFO. This is common, right? And often tricky to nail down.
Yes, DFO is a really common complication present in maybe up to 20% of mild to moderate diabetic foot infections and potentially 50 to 60% of the severe ones.
Wow, that high.
Yes. And what makes it challenging is differentiating it from other things, especially Charcot neuroarthropathy. The clinical pictures can overlap significantly, and sometimes they even coexist, which makes the diagnosis a real dilemma.
So this raises that important question you mentioned earlier. How do we definitively establish if osteomyelitis is present when things look so ambiguous, especially with potential confounders like Charcot?
Right. And we always have to remember those underlying risk factors driving diabetic foot infections in the first place. The neuropathy, the vasculopathy, and the impaired immune response, that immunopathy. They set the stage.
Okay, so diagnosis. The guidelines suggest a stepwise approach. Where do we start clinically?
For patients who present with a diabetic foot infection and an open wound, the guidelines suggest performing a probe-to-bone test as part of the initial clinical assessment, grade 2C recommendation.
The probe-to-bone test. Simple, right. But how good is it?
It's simple and inexpensive, yes.
There is.
Its diagnostic accuracy is, well, it's fair. Sensitivity is around 60%, but specificity is quite high, maybe 91%. Its positive predictive value is pretty good, maybe 89%, but only in patients where you already have a high suspicion, a high pretest probability of osteomyelitis.
So if it's positive, it's quite suggestive, especially if you already suspected it.
Exactly. But, and this is crucial, a negative probe-to-bone test does not rule out osteomyelitis. You absolutely need further testing if the probe doesn't hit bone, but you still have clinical suspicion.
Okay, so probe to bone is a useful starting point, but not definitive, especially if negative. What's next? Imaging.
Yes, imaging comes next. For all new diabetic foot infections, the guidelines suggest obtaining serial plain radiographs of the affected foot. Grade 2C recommendation again.
Serial, meaning more than one. And what are we looking for?
Yes, serials is important. We're looking for bone abnormalities, things like cortical erosion, periosteel reaction, maybe bone destruction. Also looking for soft tissue gas, which indicates a more severe infection, or any radiopaque foreign bodies that might be hiding in there.
How good are plain x-rays for diagnosing osteomyelitis?
Honestly, their sensitivity and specificity are relatively low for confirming or excluding osteo. Sensitivity around 54%, specificity maybe 68%.
Not great.
No. And a single set of x-rays early on might look completely normal, even if osteo is present. Changes often take at least 2 weeks to become visible. That's why the serial aspect is key. Comparing films over time is much more predictive than just one study. They serve as a good initial screen, maybe rule out gas or foreign bodies, but they're often insufficient for a definitive diagnosis of osteomyelitis itself.
Okay, so plain films are a start, but often not the end of the story. What if we need more sensitive or specific imaging? Say we suspect a soft tissue abscess, or we're still really unsure about osteomyelitis.
In that situation, the guidelines strongly recommend moving to magnetic resonance imaging, or MRI. MRI is recommended as the study of choice. That's a grade 1B recommendation.
Grade 1B. So MRI is really the heavyweight here.
It really is. MRI has excellent pooled sensitivity, around 90%, and pretty good specificity, maybe 79%. It's great at showing bone marrow edema, soft tissue inflammation, abscesses. It's a powerful tool for this.
Are there downsides to MRI?
Yes, definitely. Availability can be an issue. It's expensive, and some patients can't have an MRI due to pacemakers or claustrophobia. And even with MRI strengths, differentiating osteomyelitis from acute Charcot neuroarthropathy can still be challenging because both can cause similar signal changes in the bone marrow and soft tissues.
Okay, so if MRI is contraindicated or just not available, what's the next best alternative?
If MRI is off the table, the guidelines suggest a nuclear medicine scan specifically, a leukocyte or antigranulocyte scan, preferably combined with a bone scan like a technetium 3-phase bone scan. That's a grade 2B recommendation.
How do those compare to MRI?
Well, these nuclear medicine scans tend to have high sensitivity. They're good at picking up inflammation, but their specificity is relatively low. Lots of things besides osteomyelitis can cause increased uptake on these scans, including Charcot or even just overlying cellulitis. Combining the white cell scan with the bone scan helps improve specificity a bit.
Okay, so MRI is preferred. Nuclear scans are the backup if needed. Now, what about getting the definitive diagnosis, especially in those high-risk patients?
Right. For patients where the risk of DFO is high, or the diagnosis remains uncertain after imaging, the guidelines are very clear. The diagnosis is most definitively established by the combined findings on bone culture and histology. Grade 1C recommendation.
Bone culture and histology. So you need a piece of the bone itself.
Yes. And the guidelines specifically recommend that when bone is being debrided anyway, as part of the treatment for osteomyelitis, a sample must be sent for both culture and histology.
That seems logical. Kill two birds with one stone treat and diagnose definitively.
Exactly. This is truly the gold standard for diagnosis. Now, what if the patient isn't undergoing bone debridement right away? Maybe you're trying conservative management first.
Yeah, what then?
In that situation, the guidelines suggest that clinicians should strongly consider obtaining a diagnostic bone biopsy if there's still diagnostic uncertainty after imaging, or if the soft tissue cultures aren't giving useful information, or perhaps if the patient isn't responding to empirical antibiotic treatment. That's a grade 2C recommendation.
Why is getting bone culture so much better than just culturing the wound?
Because bone specimen cultures provide far more accurate microbiologic data about what's actually infecting the bone. Soft tissue cultures from the overlying wound are often contaminated with skin flora or other bacteria that aren't the real culprits deep down. Getting the bone culture allows for truly tailored antibiotic treatment directed at the specific pathogen, and that leads to significantly better outcomes. Avoids unnecessarily broad or incorrect antibiotic use.
Okay, that makes perfect sense. Target the actual enemy. So let's recap DFO diagnosis. It's a multimodal step-by-step process. Start with high clinical suspicion, use the probe to bone test, grade 2C, as an initial tool, but know its limits. Then get serial plane radiographs, grade 2C, as a baseline, and to look for obvious changes, gas, or foreign bodies. If uncertainty persists, MRI is the preferred next step, grade 1B. If MRI is impossible, nuclear medicine scans are an alternative, grade 2B. But ultimately, for the most definitive diagnosis, especially on high-risk cases or when treatment isn't working, you need bone culture and histology, grade 1C, ideally obtained during debridement or via a specific biopsy, grade 2C. That guides the most effective targeted treatment.
Precisely. It's about escalating the investigation logically until you have the certainty needed to treat appropriately.
Right. Okay, diagnostic challenge time again. Let's say you have a 70-year-old diabetic patient. Chronic, non-healing ulcer on the plantar aspect of his left foot. Known peripheral neuropathy. You do the probe to bone test, and it's positive you feel grating bone. Plain radiographs show some bony changes, but they're kind of nonspecific. You strongly suspect osteomyelitis. Which of the following diagnostic steps would provide the most definitive confirmation and best guide specific antibiotic therapy? Is it A, initiate empirical broad-spectrum antibiotics based on your strong clinical suspicion? B, obtain soft tissue cultures from the wound surface and start targeted antibiotics based on those? C, perform an MRI of the foot to get a better look at the bone involvement? Or D, obtain a bone biopsy for culture and histology?
Okay, positive probe to bone, nonspecific X-ray changes, high suspicion, need definitive diagnosis and guidance for antibiotics.
Take a moment.
Well, empirical antibiotics, A, are often necessary initially, but don't confirm the diagnosis or identify the specific bug. Soft tissue cultures, B, are unreliable for osteo. MRIC is great for seeing the extent of involvement and confirming suspicion, but it doesn't tell you the specific bacteria. So the answer has to be D, obtain a bone biopsy for culture and histology.
Exactly. The guidelines state diagnosis is most definitively established by bone culture and histology, grade 1C. And critically, those bone cultures provide the accurate microbiologic data needed for tailored antibiotic therapy, which is far superior to empirical therapy or therapy based on potentially misleading soft tissue cultures. MRI confirms the presence and extent, but biopsy confirms the cause and guides specific treatment.
That's the key distinction. Biopsy gives you the microbiological answer.
Perfect. Okay, let's move on to the hands-on part. Wound care for diabetic foot ulcers. This requires, as you put it earlier, a kind of precise dance, doesn't it?
It really does. Yeah. Attentive wound care is multifaceted. You need frequent inspection, proper irrigation, regular debridement, choosing the right protective dressings, diligent infection and inflammation control, and always underpinning it, effective plantar offloading.
All those pieces need to work together.
Absolutely. They're all foundational and essential for creating and maintaining that optimal wound environment, moist, clean, non-infected, that allows the wound to progress through the healing phases. Granulation, epithelialization, and finally, full, timely closure. It's an iterative process, too. You're constantly reassessing and adjusting.
The guidelines emphasize frequent evaluation, don't they, at 1 to 4 week intervals, and actually measuring the wounds.
Yes. Grade 1C recommendation for frequent evaluation and measurement. There's a very practical reason for this. We know from studies that seeing a 10 to 15% reduction in wound size per week or achieving about a 50% area reduction within the first 4 weeks of treatment. Those are strong early predictors of eventual healing. They also predict fewer complications down the line. So measuring regularly helps you track progress objectively. Are we on the right path? Or do we need to change something because the wound isn't shrinking as expected? It guides clinical decision-making.
That makes sense. Quantify the progress. What about infection?
Critically important, the guidelines recommend evaluating all diabetic foot wounds for signs of infection right at the initial presentation. Grade 1B recommendation.
Look for redness, warmth, swelling, purulence.
Exactly. And if infection is suspected or confirmed, this should be followed by an initial sharp debridement of the infected ulcer. And, of course, urgent surgical intervention is needed if you see signs of deep space infection like abscess, gas in the tissues, or necrotizing fasciitis. Those are emergencies.
And for managing the infection itself medically.
The guidelines actually suggest, following the Infectious Diseases Society of America, the IDSA guidelines for treating diabetic foot infections. That's an ungraded recommendation, basically deferring to the established expertise in that specific area.
Okay, now wound dressings. This can be confusing. There are so many products out there. What's the core principle?
The core principle, and this is a grade 1B recommendation, is to use dressing products that achieve 3 main goals. Maintain a moist wound bed, control excess exudate, and prevent maceration, that's breakdown of the surrounding intact skin.
Maintain moisture, control wetness, protect the edges.
You got it. A moist wound bed has been the documented standard of care for a long time. It promotes cell migration and healing. But here's the key takeaway on products. No single type of dressing product has been definitively proven superior over another for actually promoting healing.
Really? So the fancy expensive ones aren't necessarily better than the simpler ones?
Not necessarily in terms of ultimate healing rates in good comparative trials. The choice of dressing should be pragmatic. Base it on the wound's characteristics. Is it dry? Then maybe use a hydrogel. Is it heavily exudating? Then maybe use a foam or an alginate. Also consider cost, ease of use for the patient or caregiver, and availability. Match the dressing function to the wound's needs at that particular time.
Practicality rules. Okay, let's talk debridement. Removing dead tissue. How important is that?
Extremely important. The guidelines strongly recommend sharp debridement of all devitalized tissue slough, Escher, and also the surrounding callus material from diabetic foot ulcerations. And this should be done regularly, typically at 1 to 4 week intervals. Grade 1B recommendation.
Why is debridement so crucial? What does it actually do?
Several things. First, it removes the dead tissue that bacteria love to feed on, so it reduces the bacterial burden in the wound. Second, it allows you to accurately assess the wound's true size, depth, and characteristics. You can't see what's underneath dead tissue. Third, removing that necrotic burden and inflammatory stimulus actually encourages the healing process to restart or progress. And finally, removing the surrounding callus directly reduces pressure on the wound edges.
So, multiple benefits. Sharp debridement is recommended. Are there other methods?
Yes, there are various methods mentioned: surgical debridement, which is sharp debridement, larval therapy, maggots, hydrotherapy, ultrasound-assisted debridement, enzymatic ointments. But the guidelines point out there's a lack of strong evidence showing any single technique is definitively superior to others overall.
So how do we choose?
The suggestion, grade 2C, is that after an initial sharp debridement, the subsequent choice of method should be based on the clinical context. What's available? What can the patient tolerate? What's the cost effectiveness? Is sharp debridement feasible in the clinic setting? Maybe enzymatic is better for home use between visits. It's about tailoring the method. Oh, and notably, wet-to-dry dressings, which used to be common, have really fallen out of favor because they're non-selective. They rip off healthy tissue along with dead tissue.
Right, good point about wet to dry. Okay, so regular debridement is key. Method can be tailored. But what happens when, despite good standard care offloading dressings debridement, the ulcer just isn't healing? The recalcitrant ulcers.
That's where we need to consider escalating therapy. If a diabetic foot ulcer fails to show significant improvement, and the benchmark often used is that 50% wound area reduction we talked about after a minimum of 4 weeks of good standard wound therapy, then the guidelines recommend considering adjunctive options. Grade 1B recommendation to consider these.
Adjunctive therapies, advanced stuff.
Yes, advanced wound care modalities. But, and this is really important before jumping to these advanced therapies, you must reevaluate the basics.
Ah, okay. Like what?
Is the offloading truly adequate? And is the patient adhering to it? Is there underlying uncontrolled infection that needs addressing? Is the vascular status sufficient for healing, or has it worsened? You have to optimize that foundational care first. As you said earlier, it highlights a crucial clinical pivot point. Knowing when to intensify therapy, knowing what robust options are available, but only after making sure the basics are truly optimized.
Makes perfect sense. Don't jump to fancy stuff if the simple things aren't right.
Yeah.
Okay, assuming the basics are optimized, what are some of these key adjunctive options?
Well, the guidelines mention several categories. One is negative pressure wound therapy, or NPWT.
The wound VAC.
Exactly. The suggestion, grade 2B, is to consider it for chronic diabetic foot wounds that aren't healing as expected after 4 to 8 weeks. Studies show it can help achieve faster wound closure, may reduce secondary amputations, and sometimes decrease hospitalizations compared to standard care alone.
Okay, NPWT. What else?
Then there are biologics and skin substitutes. This is a broad category. One specific agent mentioned is platelet-derived growth factor, or PDGF. The commercial product is bicapelmin gel.
What does that do?
It's a recombinant human growth factor that stimulates tissue regeneration and angiogenesis, new blood vessel formation. The suggestion, grade 2B, is to consider it for recalcitrant diabetic foot ulcers.
Any drawbacks?
Well, there is a Food and Drug Administration black box warning regarding a potential increased risk of cancer mortality in patients who used multiple tubes of the gel. The data behind this warning is somewhat limited and debated, but because of it, its use is generally restricted to refractory cases where other options haven't worked, and after a careful risk-benefit discussion with the patient.
Okay, so PDGF is an option. With caveats, what other biologics?
The guidelines also suggest considering living cellular therapy, grade 2B. This includes products like Apligraf or Dermagraft.
What are those?
They're essentially bioengineered skin substitutes. Apligraf is a bilayered construct with keratinocytes and fibroblasts derived from neonatal foreskin. Dermagraft uses human neonatal fibroblasts seeded onto a scaffold. They work by supplying growth factors and creating a matrix that encourages the patient's own cells to migrate in and heal the wound. Trials have shown they can improve healing rates and reduce complications compared to standard care for stubborn ulcers.
Interesting. Living cells helping healing. Any others in this category?
Yes, also extracellular matrix products, grade 2C suggestion. These are acellular scaffolds, often derived from human dermis, like ground jacket, or porcine small intestinal submucosa, like Oasis. They provide a natural scaffold for tissue ingrowth. Specific trials have shown benefits over standard care for these as well.
So, several types of biologics and matrices. Is there anything else non-topical?
Yes, hyperbaric oxygen therapy, or HBOT. The suggestion, grade 2B, is to consider HBOT for diabetic foot ulcers that have adequate perfusion, meaning blood flow isn't the primary problem, but are still failing to respond after 4 to 6 weeks of good conservative management.
How does breathing high-pressure oxygen help a foot ulcer?
It significantly increases the amount of dissolved oxygen in the blood plasma. This hyperoxygenated blood reaches the wound tissues, supporting cellular metabolism, promoting angiogenesis, enhancing fibroblast function, and helping neutrophils kill bacteria more effectively. Trials have shown HBOT is associated with increased healing rates and reduced major amputation rates in carefully selected patients with non-healing ulcers.
Okay, quite a range of advanced options. NPWT, PDGF, living cellular therapies, extracellular matrices, and HBOT.
Right. The key is they are adjunctive, they add to but don't replace good basic care.
Let's do a quick micro recap for wound care. It's an iterative process. Frequent evaluation and measurement, grade 1C, track progress, address infection early, grade 1B, and follow IDSI guidelines. Use dressings that maintain moisture, manage exudate, and protect edges, grade 1B, but the specific product choice is less critical than the function. Regular sharp debridement of devitalized tissue and callus is essential, grade 1B, with method choice being flexible, grade 2C. For ulcers not healing after at least 4 weeks, despite optimizing standard care, offloading, infection control, perfusion, consider adjunctive therapies, grade 1B. Options include NPWT, grade 2B, PDGF, grade 2B with caveats, living cellular therapy, grade 2B, extracellular matrices, grade 2C, and HBOT, grade 2B for well-perfused wounds. The critical step is always reevaluating the basics before escalating.
Excellent summary. Always check the foundation before adding more layers.
Okay, time for a wound care scenario. A 55-year-old patient has a chronic plantar diabetic foot ulcer. It hasn't improved significantly after 6 weeks of meticulous care. He's in an irremovable cast walker, getting regular sharp debridement, and using appropriate moist wound dressings. His hemoglobin A1C was just checked, and it's 7.2%. His pedal pulses are easily palpable, suggesting good blood flow. What's the most appropriate next step in his wound management, based on the guidelines? A. Continue the current standard care regimen for another 6 weeks, just give it more time. B. Recommend immediate surgical closure of the wound. C. Initiate an adjunctive therapy, such as negative pressure wound therapy. Or D. Prescribe systemic antibiotics because it must be an underlying infection.
6 weeks, no improvement despite good standard care, good perfusion, decent glycemic control.
Take a moment. What do the guidelines suggest when standard care fails after 4+ weeks?
They suggest considering adjunctive therapies. He's met the criteria. 4 weeks, failure to improve despite optimized basics. The answer should be C. Initiate an adjunctive therapy, such as negative pressure wound therapy.
Precisely. The guidelines recommend considering adjunctive therapies, grade 1B, in this exact situation. Continuing the same failing regimen, A, isn't logical. Surgical closure, B, isn't usually appropriate for a chronic ulcer that hasn't granulated without addressing why it's not healing. Prescribing antibiotics, D, without clinical signs of infection isn't indicated. His palpable pulses and lack of mention of infection signs suggest perfusion and infection aren't the primary current roadblocks. Time to escalate to an adjunct.
Right. He's the classic candidate for considering something like NPWT or one of the biologics.
Great. Now for our final and hugely important section, peripheral arterial disease, or PAD, and the diabetic foot ulcer. You mentioned earlier how challenging this intersection is.
It really is. This combination is particularly sinister. PAD is incredibly common in diabetic patients, maybe 10 to 40% prevalence, depending on the population studied.
And the outcomes are poor?
Devastatingly poor. When a patient has both diabetes and PAD, significant enough to cause foot problems, their 5-year mortality rate approaches 50%.
50% in 5 years. That's higher than many cancers.
It is, and even starker. If they undergo an amputation due to PAD and diabetes, their 2-year mortality is also around 50%. It's a marker of very advanced systemic disease. There's also data suggesting that over recent decades, the proportion of foot ulcers that are ischemic or neuroischemic, meaning involving poor blood flow, seems to be increasing compared to purely neuropathic ulcers.
So recognizing PAD early and managing it effectively is absolutely critical in these patients. How do the guidelines recommend we screen for it?
They suggest starting ankle brachial index, or ABI, measurements for patients with diabetes when they reach 50 years of age. That's a grade 2C recommendation.
Start screening at 50 with ABI. What about patients who are already considered high risk for foot problems?
For those high-risk patients, remember, prior ulcer, abnormal vascular exam findings already, history of peripheral vascular intervention, or known atherosclerotic cardiovascular disease elsewhere, the guidelines suggest annual vascular examinations of the lower extremities and feet. This should include not just a physical exam, but also ABI and toe pressures. Grade 2C again.
Okay, annual checks for high risk. Now, what about someone who already has a diabetic foot ulcer? How often should we assess their perfusion?
For all patients with an existing diabetic foot ulcer, the guidelines make a stronger recommendation. Grade 1B for annual assessment of pedal perfusion. This assessment should be comprehensive, using ADI, looking at ankle and pedal Doppler arterial waveforms, and measuring either toe systolic pressure or transcutaneous oxygen pressure, which is often called TCPO2.
Why the emphasis on toe pressures or TCPO2 in addition to ABI?
Because ABI can be unreliable in diabetic patients. Medial arterial calcification hardening of the middle layer of the artery wall is very common in diabetes. This makes the arteries incompressible, leading to falsely elevated ABI readings, sometimes even above 1.3 or 1.4.
So a normal ABI could be misleading.
Absolutely. It might mask significant underlying PCAD. Toe arteries are generally spared from this type of calcification, so toe systolic pressures give a more accurate picture of distal perfusion. TCPO2 directly measures the oxygen delivery to the skin surface, which is ultimately what's needed for wound healing.
And how predictive are these measures?
Very. The evidence shows an ADI less than 0.8 significantly increases amputation risk, and studies suggest that toe pressures, or TCPO2, might be even better than ABI at predicting wound healing potential and amputation risk in this population. Low values directly correlate with poor healing outcomes.
Okay, so comprehensive annual perfusion assessment, ABI, waveforms, toe pressure, or TCPO2, is vital for anyone with a DFU. Now, what if we find significant PAD in a patient with a non-healing ulcer? What about revascularization?
If a patient has a diabetic foot ulcer and PAD that is thought to be contributing to the lack of healing, The guidelines recommend revascularization. This can be done by either surgical bypass or endovascular therapy. That's a grade 1B recommendation, a strong signal that intervention is beneficial.
So fix the plumbing if it's blocked and the wound isn't healing.
Essentially, yes. But deciding who benefits most and how to revascularize involves significant clinical judgment. It's not automatic.
What helps guide that decision?
Predicting benefit can be helped by using risk stratification systems like the Society for Vascular Surgery's WIFI classification that stands for wound, ischemia, and foot infection. It helps categorize limb threat based on the severity of all three components.
WIFI score, okay.
But ultimately, selecting the right patient requires combining that clinical judgment with a careful interpretation of the objective perfusion test we just talked about, along with considering the extent of the wound and any infection.
And the choice between surgical bypass and endovascular therapy, balloons and stents versus open surgery.
That depends on many factors. The pattern of the arterial disease, is it long segment blockages or shorter lesions? The patient's overall functional status and surgical risk. The availability of a good vein conduit for bypass, which is generally superior to prosthetic grafts in this setting, especially with tissue loss, the degree of ischemia, the wound extent again, the presence of infection, and, frankly, the available local expertise.
Is one generally better than the other in diabetic patients?
There's an ongoing debate, and we lack definitive randomized trials specifically in diabetic patients with foot ulcers, comparing the two head-to-head extensively. Some retrospective studies suggest endovascular therapy might lead to more repeat interventions later, but it's less invasive up front. For patients with extensive disease but who are good surgical candidates and have a suitable vein, bypass might offer better long-term durability. Both modalities, however, are critically important tools for limb salvage. The choice needs to be individualized.
Individualized care based on multiple factors. Got it. And one last critical point you mentioned, the interplay between infection and PA.
Yes, this cannot be overstressed. Infection in a limb that already has compromised blood flow due to PA is especially detrimental. It dramatically increases the likelihood of the wound not healing and progressing towards amputation. Studies have shown this combination can triple the likelihood of non-healing.
So what's the management strategy when you have both infection and PA?
It has to be aggressive and coordinated. First, aggressive infection control, appropriate systemic antibiotics, and timely, thorough surgical debridement to remove all infected and necrotic tissue. Control the sepsis.
Okay, infection control first.
Yes. And then prompt revascularization once the infection is adequately controlled. You generally don't want to revascularize right through gross pus, but you can't delay too long either. If a diabetic foot wound, especially one complicated by PAD, isn't responding promptly to standard wound care after initial infection drainage and debridement, revascularization should be very strongly considered and quickly. Don't wait weeks and weeks if the perfusion is inadequate.
Get the infection under control, then restore blood flow ASAP.
That's the mantra.
Okay, let's recap PID and the DFU. It's a deadly combination with high mortality. Early and accurate PID assessment is vital. Start ABI screening at age 50, grade 2C. Do comprehensive annual perfusion checks, ABI waveforms, two-pressure TCPO2, grade 1B, for all patients with a DFU, recognizing ABI limitations due to calcification. If PAD is contributing to non-healing, revascularization, bypass or endo is recommended, grade 1B. Use tools like WIFI and clinical judgment to select patients. Individualize the revascularization approach, and crucially, aggressively control infection first, then promptly revascularize once infection is managed, as this combination is particularly dangerous.
An excellent summary of a very complex but critical area.
All right, final scenario. A 72-year-old patient, long history of diabetes, has a non-healing left heel ulcer. USS perfusion. ABI is 0.6, TCPO2 is quite low at 25 millimeters of mercury. There are also clinical signs of local infection around the ulcer, redness, warmth, some drainage. What is the most appropriate initial management strategy? A, focus solely on aggressive wound debridement and maybe just topical antibiotics. B, immediately proceed with empiric revascularization to improve blood flow. C, prioritize aggressive infection control, systemic antibiotics debridement, and then fully assess for and plan revascularization. Or D, recommend a removable cast walker for offloading and see what happens without further vascular workup for now.
Okay, clear ischemia, low ABI, low TCPO2, and signs of active infection. Need the initial strategy.
Take a moment. Infection plus ischemia, what comes first?
Infection control has to come first when it's active like this. Revascularizing through pus is risky.
So,
The answer is C. Prioritize aggressive infection control, systemic antibiotics, debridement, and then assess for revascularization.
Exactly. The guidelines stress controlling infection first in the setting of PAD. While revascularization is clearly needed given the ischemia, addressing the active infection is the immediate priority to stabilize the limb before potentially seeding a new graft or vessel during revascularization. Option A ignores the systemic infection and severe ischemia. Option B ignores the immediate infection risk. Option D ignores both the infection and the critical ischemia. You must address the infection, then urgently address the ischemia.
Textbook application of the principle, infection control, then revascularization.
Fantastic. Well, this deep dive, it really shows us, doesn't it, that managing the diabetic foot successfully isn't about one single thing. It's about the synergistic application of all these critical pieces.
Absolutely. Rigorous prevention, aggressive and appropriate offloading, precise diagnosis of complications like osteomyelitis, meticulous wound care, including timely escalation to adjunctive therapies, and targeted revascularization for PAD. It all has to work together.
Each aspect is critical, but it's putting them all together consistently that drives true success in patient outcomes, moving beyond just reacting to saving limbs proactively.
And these guidelines really provide a powerful evidence-based framework for achieving that kind of integrated multidisciplinary care. They distill so much complex information into actionable recommendations.
Which leads to a final thought, maybe a provocative question for you, the clinician listener. We've seen the strong evidence, for example, for irremovable offloading and therapeutic footwear in high-risk patients, yet we also acknowledge that patient adherence is often the biggest challenge.
It's a constant struggle.
So the question is, given that reality, what innovative approaches can we as clinicians implement beyond just writing the prescription? How can we truly empower our patients to embrace these potentially life-saving, limb-saving interventions and integrate them into their daily lives? It's not just about what we recommend, but how we ensure those recommendations actually translate into consistent, life-changing habits for the people we care for.
That's a challenge for all of us to think about moving forward, how to bridge that gap between evidence and real-world adherence.
Indeed. Well, thank you so much for joining us on this critical deep dive into the management of the diabetic foot based on the latest guidelines. We sincerely hope this comprehensive exploration provides you with invaluable, practical insights for your clinical practice.
Thank you.
Until next time on the Deep Dive.